Hello, everyone. Welcome back, and thank you for sticking this far and getting this far into pediatrics. If you are listening, I really hope that you are going to have a great study session. Um, okay, we are on page 392, Master the Board, Step 3, and we are starting with gastrointestinal diseases. Um, We're going to start with diarrhea here, and we have three things to talk about: the acute diarrhea, hemolytic uremic syndrome, and chronic diarrhea. Okay, so let's start with acute diarrhea here. In acute diarrhea, it says that the most common cause of acute diarrhea in infancy is a rotavirus. So we have rotavirus as the most common one, but the most common cause of bloody diarrhea, which is different, are multiple. Um, it's going to be Campylobacter, amoeba, which is the Entamoeba histolytica type, Shigella, E. coli, and Salmonella. So those would be the most common causes of bloody diarrhea. Now, next we have a list of those organisms that we talked about and a bunch of others that are causing diarrhea or acute diarrhea. And there are some specific characteristics for each microbe. If you've done step one, this is going to be easy. If you haven't, I highly suggest that you would try and memorize those or read a little bit more to understand. So, and rotavirus, and this is the only virus on the list, it's a double-stranded DNA virus. So there are DNA and RNA virus and single-stranded and RNA, single-stranded DNA, double-stranded DNA, and so on. And this type is a double-stranded DNA virus. Okay, all right. The Shigella is a gram-negative, non-spore-forming rod. The Campylobacter, it says that it's a gram-negative, but it's a spiral that is motile with a flagella. So it has a flagella, motile, and it is spiral, gram-negative. Salmonella is a gram-negative rod that is motile. Clostridium difficile, this is a gram-positive one. So this is the first gram-positive. We had 3 gram-negative ones: the Shigella, the Campylobacter, and the Salmonella. And this is spore-forming bacteria. So the Clostridium is spore-forming. The Shigella is non-spore-forming. The Giardia, this is non-bacterial. It's an anaerobic protozoan with the flagella. Then we have Cryptosporidium, and this is again a protozoa that mostly affects immunocompromised patients. So we're going to see it in diabetics, for example. Okay, so the best initial test is a stool examination for the following. First, stool cultures with blood, leukocytes, suspected hemolytic uremic syndromes, and so on. This would help. In Clostridium difficile toxin, if a recent history of antibiotics is in the stem, and we can look for ovum parasites in the stool examination. The best initial therapy is hydration and fluid and electrolyte replacement. As in the case here that says that the most common cause is a rotavirus, usually it's self-limiting, and the most important thing to do is to prevent dehydration. So that's why the best initial therapy is hydration and fluid and electrolyte replacement. Do not use antidiarrheals in children. Antibiotics are rarely used, even in bacterial diarrhea, and this is except for some specific cases here. So antibiotics, again, are rarely used, even in bacterial diarrhea, and we have some exceptions. Okay, so if we have a diagnosis of Shigella, we would give trimethoprim sulfamethoxazole. If we are suspecting the Campylobacter, this is self-limiting. Erythromycin would speed up the recovery and reduces carrier state, and is recommended for patients with severe disease or if there is dysentery. So those are the cases that we'd give antibiotics. So to speed up the recovery and reduce the carrier state, and recommended for patients with severe disease or dysentery. Salmonella, the treatment is indicated only for patients who are less than 3 months old. The stem says that the patient is 4 months and older. We do not give that. And also, who are toxic and who have disseminated disease or have Salmonella typhi. So the typhi here would require the treatment. So again, treatment is indicated only for patients who are less than 3 months old or who are toxic, who have disseminated disease, or who have a Salmonella typhi. Clostridium difficile, of course, we give metronidazole or PO vancomycin, and discontinuation of other antibiotics. Discontinuation of other antibiotics because the cause is usually the antibiotics. Entamoeba histolytica and or giardia, we give metronidazole. Cryptosporidium, antiparasitics, that we would give that, and watch for malnutrition in pediatric patients. So this is going to be really easy so far. We only give Shigella trimethoprim sulfamethoxazole. The Campylobacter is self-limiting. We give erythromycin in specific conditions. Salmonella with treatment is indicated for patients who are less than 3 months, toxic, disseminated disease, Salmonella typhi. Clostridium difficile, Entamoeba histolytica or giardia, we give metronidazole. But in Clostridium difficile, we stop the other antibiotics, or we can give vancomycin PO per oral. And finally, the Cryptosporidium, we give antiparasitics and watch for malnutrition. So that's been the acute diarrhea. Now let's look at hemolytic uremic syndrome. In hemolytic uremic syndrome, this is a complication of acute invasive, which is another term for bloody diarrhea, and most commonly it's caused by E. coli O157 H7. So this is a specific type of E. coli that would be most commonly associated with the hemolytic uremic syndrome. Again, E. coli O157 H7, but it can also be caused by Shigella, Salmonella, and Campylobacter. We never give antibiotics in suspected cases of E. coli O157 H7 because there is an increased risk of developing the hemolytic uremic syndrome. That's why we never give antibiotics, like we mentioned before, unless the specific cases we talked about. In young children, they present 5 to 10 days after the infection with pallor. This is due to microangiopathic hemolytic anemia. They're going to also be present with weakness, oliguria, and acute renal insufficiency. This is the renal part. And the anemia is the hemolytic part, or in general they are present with anemia and an acute renal failure. Hemolytic uremic syndrome is the most common cause of ARF in young children. ARF as in acute renal failure in young children. We look in such cases, we look for anemia. We're going to see helmet cells, Burr cells, fragmented cells, and this is due to the microangiopathic hemolytic anemia again. We're going to see also elevated white blood cell counts. We're going to have negative Coombs test, and this is due to just means that it is not due to an allergic reaction or something like that. And the low platelets, we're going to see low platelets of less than 100,000 per cubic millimeter. We're going to have low-grade microscopic hematuria and proteinuria. As a treatment for such a case, we're going to have some supportive care. We're going to look for the hypertension and treat the hypertension in such cases. Aggressive nutrition, and we can have early dialysis. The prognosis is more than 90% of patients would survive the acute stage, and a small number would develop the end-stage renal disease. After that, we're going to monitor the blood pressure for 5 years, and then monitor the renal function with BUN and creatinine for 2 to 3 years after the hemolytic uremic syndrome. So there is a follow-up period, at least 5 years for the blood pressure, and renal function with BUN and creatinine for 2 to 3 years. And that's been the hemolytic uremic syndrome. And now finally we're gonna look into the chronic diarrhea here. And chronic non-specific diarrhea, it presents with the normal weight, height and nutritional status with no fat in stool. That is in general. History usually includes excessive intake of fruit, juice, or carbonated fluids, or low-fat intake. If there is weight loss and stool with high fat, we should screen for malabsorption syndromes. And we're going to talk about the malabsorption syndromes in the next section here. Okay. So the next thing that we are going to talk about is going to be the malabsorption, celiac disease, and those will cause the chronic diarrhea, both of them. In the malabsorption, it says that here that it may appear from birth or after the introduction of new foods. So either this or that. And the diagnostic testing that we're going to do is going to be different depending on what we are suspecting here. If for fat malabsorption, the best initial screening test is the Sudan black stain. And the best confirmatory test is going to be a 72-hour stool for fecal fat. And this is the gold standard for steatorrhea. So if we want to diagnose such a case of steatorrhea, we should do the 72-hour collection of stool for fecal fat. 72-hour stool for the fecal fat. And finally, we can have a serum trypsinogen screens, and this is for pancreatic functions. And see if the pancreas is not really functioning well and would cause the steatorrhea. And this has been the fat malabsorption. For the protein malabsorption, this cannot be evaluated directly. So best initial test is going to be the spot stool alpha-1 antitrypsin level. And this would give an indication of fat malabsorption. For vitamins and minerals, we measure the serum iron, folate, calcium, zinc, and so on, and determine if there has been a malabsorption or not. On the left side, we have a note here that says pancreatic insufficiency presents with a prominent steatorrhea. We get a sweat chloride test to rule out cystic fibrosis in such cases. In giardiasis is the only infection that causes chronic malabsorption. If giardiasis is suspected, we order a duodenal aspirate / biopsy, or we can have an immunoassay just to diagnose and if we have a suspected case of giardiasis. Malrotation, it can present with malabsorption and incomplete bowel obstruction, so bear that in mind. So next here we have celiac disease. And celiac disease, of course, it presents within the first 2 years of life. It's going to have, the patient is going to have chronic diarrhea and failure to thrive, of course, sometimes growth retardation and anorexia. The symptoms occur with exposure to gluten, rye, wheat, and barley. There's going to be an intolerance in a lifelong. So this is not an acute condition. It's going to have an effect, a lifelong effect on the patient. To diagnose such a case, well, there is a best initial test and the most specific one. The best initial diagnostic test is the anti-transglutaminase antibodies, and the most specific test is histology on biopsy, and the most definitive, of course. So best initial test again is anti-transglutaminase antibodies, and the most specific one is histology on biopsy. The treatment for celiac disease is a lifelong, strictly gluten-free diet. So it's prevention rather than preventing the symptoms, rather than having eradicating the disease itself. So celiac patients, we have a note here on the side. It says that celiac patients have an increased lifetime risk of osteoporosis and GI malignancies. And this is most commonly enteropathy-associated T-cell lymphoma. So again, celiac disease, we have two things to worry about in those two cases, and that's going to be osteoporosis and the GI malignancies, most commonly enteropathy-associated T-cell lymphoma. Okay, so that's been the chronic diarrhea with malabsorption and celiac disease. Now let's take a look at the GERD, or the gastroesophageal reflux disease. We have here a question. The whole thing is in the form of question, and it says a 4-month-old girl presents with several weeks of chronic wheeze and apneic episodes 2 to 3 minutes after feedings. She has been spitting up after feeds since birth. The infant has presented to the office on several occasions with the same complaint despite adjustments in feed techniques and formula consistency. She is at the 5th percentile for weight, which of the following is the most appropriate intervention? And then we have here erythromycin, fundoplication, metoclopramide, omeprazole, and ranitidine. So of course, if you're suspecting a gastroesophageal reflux disease, we're going to either give omeprazole or ranitidine. Those are the most typical ones. But ranitidine would be the first choice, I would say. Let's see what the answer is. And it says E, ranitidine. And the explanation says that GERD results from incomplete esophageal sphincter tone early in life. Symptoms typically resolve by 12 to 24 months. The diagnosis is going to be clinical in such a case like that. However, the best initial test is an esophageal pH monitoring that can give us an indication. High pH, of course, would indicate that. Endoscopy is used to evaluate for erosive gastritis or other complications like ulcers. The best initial management is a change in feeding technique and thickened feeds, like has been done in the stem of the question. H2 receptors are considered first line in children because of the safety profile. However, proton pump inhibitors tend to be more effective, of course, in suppressing gastric acid production. That's why we start with ranitidine. And that's been the GERD. Really easy, and we're done. All right. Now let's take a pyloric stenosis here. And again, it's in the form of a question, which I really like, actually. A 4-week-old boy presents with recurrent vomiting after feeds. So again, 4-week-old. Remember the age of the boy. This is important. So vomitus is a non-bilious in nature. Laboratory findings include chloride of 88 milliequivalent, potassium of 3.1 milliequivalent, sodium of 146, and pH of 7.48. What is the best initial test in the workup for this infant? And it has ABCE. And A is an abdominal X-ray, B is a barium enema, C is CT scan of the abdomen, D is esophageal pH monitoring, and E is on ultrasound. And remember, this is the best initial test. The answer here says E, ultrasound. So we're going to ultrasound that case. Well, the case here, as an explanation here, it says that the case will describe a firstborn European Caucasian male. Remember that part. With non-bilious projectile vomiting. So non-bilious. So we're not having any bile in it. And this is typically in the first 6 weeks of life. That's why we noted the age of the patient. It also says here that there is a hypochloremic and metabolic alkalosis, and a firm mobile 1-inch mass is often palpated in the epigastrium. The best initial test is an ultrasound of the abdomen, and the treatment is pyloromyotomy. The abdominal X-ray is going to be less useful in identifying the pyloric stenosis, and it's not the test of choice in this case. And if we have high clinical suspicion, just ultrasound is better. A CT scan is not indicated. That this is to prevent the exposure to radiation when a more appropriate test is available, which is an ultrasound here. So and that's been the general idea about pyloric stenosis. In the next page, we have here a lovely illustration of the anatomy of the stomach, and it has the body, the fundus, and so on. And we have here the pancreatic duodenal opening, the pyloric untum, and the sulcus intermedius. And we see here the pyloric part that might be stenotic. In the description, it says that pyloric stenosis is going to be caused by hypertrophied pylorus. The hypertrophied pylorus obstructs the outlet, so nothing passes to the duodenum, and projectile vomiting ensues. The vomitus does not contain bile. This is an important part here, because food must be able to get to the duodenum in order to come in contact with bile. The absence or presence of bile and vomitus is the key difference here between duodenal atresia, which has atresia, no bile, and pyloric stenosis, bile. I think it should be the other way around, actually. but yeah. Yeah, it's been a mistake here. Because it says here, pyloric, the difference between duodenal atresia and between brackets it says no bile. It should be other way around. And pyloric stenosis, between brackets it says bile, and I think it should be the other way around. So pyloric stenosis, we're not going to see no bile, and in duodenal atresia, there's going to be bile. Okay, so moving on, it continues and says the hypochloremic metabolic alkalosis is also pathognomonic for the pyloric stenosis. So it's going to be low chloride and along with the metabolic alkalosis. And when we see that, we should suspect a pyloric stenosis. Vomiting causes loss of the gastric acid, which would say that's why we have the which is hydrochloric acid. And that would explain the hypochloremic state. The low chloride level prevents the kidneys from excreting bicarbonate, and this is going to lead to alkalosis. A side note says the difference between hypertrophy here, which is enlarged cells, but the same number of cells, and hyperplasia, which is normal cells, but there's more cells. Okay, and that's been the pyloric stenosis here. Next we have malrotation in volvulus, and in such cases we'll look for an infant with a bullous emesis and recurrent abdominal pain with vomiting. We always suspect that volvulus when the patient has an acute small bowel obstruction without a history of bowel surgery at all. So if we suspect obstruction without bowel surgery, it's volvulus most of the time. How are we going to diagnose the case? Well, the best initial test is an ultrasound, inversion of the superior mesenteric artery and vein, and duodenal obstruction. That's gonna be present, or we can do a barium enema. The cecum is not in the right lower quadrant, and that's gonna have the malrotation at that point. The abdominal X-ray is not going to be helpful. It's only helpful in duodenal obstruction, which will show the double bubble sign here. So again, best initial test is going to be an ultrasound, or we can do a barium enema. Either way, the treatment is surgery, of course. So that's been the malrotation and volvulus. Moving on next, we have here hematochezia. We only have two topics to talk about, which is the intussusception and hematochezia. And hematochezia presents here as a question, and it says a 2-year-old boy is brought to the office because his mother has noticed bleeding in his diaper for 1 week. The child has no complaints. Physical examination is unremarkable. And which of the following is the best initial test? So it says here a GAIAC exam, push enteroscopy, red blood cell tagged scan, technetium 99M scan, and finally an upper endoscopy. I don't really know the answer here, but it says here that the answer is D, the TC99M pertechnate scan, or the technetium scan. This is also known as the Meckel radionucleotide scan. All right, and this is the diagnostic exam for Meckel's diverticulum. In a case of intermittent painless, and this is really important, painless rectal bleeding, this is the classic presentation due to the acid-related bleeding of aberrant mucosa, which are the remnant of the embryonic sac. So this may present with intussusception as well, as remnant may become a lead point at that point, or it could be diverticulitis, which would look like an acute appendicitis at that point. So to understand this a little bit better, we need to understand that Meckel diverticulum is a remnant of the omphalomesenteric duct, and it follows the rule of 2 here. The 2 here is going to be 2% of the population would have it. Usually it's 2 feet from the ileocecal valve. This is the location. It's usually 2 inches in length, and it is 2 to 1 male to female. So we're going to see a male child, like in the case, it says here 2-year-old boy. And there are 2 types of tissues here. It has the gastric and pancreatic. Okay, so this is the Meckel's diverticulum again. Now let's talk about intussusception. In intussusception, we do have a question as well here, and it says a 16 months old child is seen for cramping and colicky abdominal pain. This has been for the past 12 hours, and he has a 1 week history of diarrhea, but developed episodes of vomiting as well, and passed black, bloody stool today. Physical examination is remarkable for a lethargic child. The abdomen is tender on palpation. Temperature is high, 101.3 Fahrenheit, and white blood count is 18,000. Just as a side note here, temperature usually is not in Fahrenheit in the exam. I took step 1, and it is in always in Celsius. So, moving on. The white blood cell count is 18,000, and which of the following is the most appropriate next step in the management? And the first one says here the antibiotic prophylaxis, bowel resection, electrolyte replacement, embolectomy, and reduction of the bowel. And it says here the most important next step in management. So the answer here is E, of course, that this is reduction of bowel, as we suspected intussusception. And reduction of the telescoped bowel is the priority of management in a patient presented with intussusception in any case at all. So do not be fooled with the high temperature to give antibiotics or electrolyte replacements and so on. The high priority is to reduction of the bowel here. And the explanation moves on. It says that intussusception is the telescoping of bowel that classically occurs in children less than 2 years. So we had that case of 16-month-old child, and it fits that criteria. This is often following gastrointestinal or upper respiratory infection, or it may occur spontaneously in patients with a lead point, like in Meckel's diverticulum, like we said before, or a polyp, or a neurofibroma, hemangioma, or something that would have a lead point here, or with a history of Henoch-Schönlein purpura. I didn't know that part. So if there is a history of Henoch-Schönlein purpura, this could indicate that he might have intussusception again. Okay. So the case will describe in general a sudden paroxysm of colicky abdominal pain in a lethargic child along with shock and fever. The classic black currant jelly stool results from mucosal necrosis due to venous obstruction, due to the intussusception, of course. And we have a lovely illustration here of the intussusception that you can take a look at the bottom of the page. So how we're going to diagnose it, diagnostic testing and treatment. The best initial test is a plain film of the abdomen, and this is to rule out any obstruction. And the next step is going to be the air enema, and this is to reduce the telescoped bowel, and which is both diagnostic again and curative. A manual reduction may be needed if radiographic reduction is not successful. And at that point, we have finished gastrointestinal diseases. That's very good. We have 28 minutes, and we're going to take some time off, 5 minutes or 10 minutes perhaps, and we're going to be back with the renal and urologic disorders. Thank you for sticking this far, and I'll see you in the next one. All right, bye-bye.